Hey guys, Dr. Haverland here. I'm just going to give us a few minutes before we get started to let everybody join, and then we will get going. Looking forward to talking with you guys for the next hour or so. Hey guys, I'm Dr. Rachel Haverland. I'm just going to give us a few minutes to let a few more people join, and then we will get started. Thanks for coming to meet with me today. Hey guys, Dr. Haverland here. I'm just going to give us 1 or 2 more minutes to let people join in, and then we will get started. Hey guys, Dr. Haverland here. I'm just going to wait 1 more minute and then we will get started once we have a few more people join. Thank you for meeting with me today. I look forward to talking with you guys over the next hour or so. So 1 more minute and we'll get started. All right, guys, we're going to get started. I'm Dr. Rachel Haverland. Thank you for joining me today. We are going to talk about why your pain keeps getting dismissed. And I think this is a very valuable and important discussion to talk about advocacy, listening to your body. So, Texas women, I want to start with something that might feel very familiar. You explain what you're feeling clearly, calmly, and somehow you still leave feeling unheard. You talk about the pain, the bloating, the exhaustion, and you hear, oh, this is normal. Your tests are all fine. This just happens. But your body keeps saying something else. And that disconnect, that's where the problem starts. Because for many women, these symptoms are often linked to conditions like endometriosis, but instead of being explained, they're dismissed. So today we're going to unpack why that happens and what your body may be actually trying to tell you. So here's what women don't realize. It's not just the symptoms, it's the pattern of what happens after you speak up. You bring it up, you're told it's normal, and then you wait. It keeps happening. You bring it up again, and you're told everything is fine. So eventually, you stop pushing and start thinking, maybe I'm overreacting. Maybe this is just how my body is. And this is what I call the dismissal loop. And it's one of the biggest reasons conditions or chronic conditions like endometriosis go unrecognized for years. Not because there's nothing there, but because no one has connected it properly. And so I want to discuss this today in depth. I am Dr. Rachel Haverland. I'm a board certified gynecologic surgeon and women's health specialist. And I want to be very clear about something. Most of the women I work with are not new to this. They've already asked questions, they've already tried to get answers, and they were told everything looks normal, nothing is wrong. Until we take a closer look, and what we often find are these patterns consistent with endometriosis? Were they ever clearly explained before? And I'm not here to label you, I'm here to help you understand what your body has been trying to say. And so I look forward to talking with you guys for this next hour or so, discussing advocacy, this dismissal loop, and why your pain might keep getting dismissed, and then how to advocate for yourself. I think this is very important. Over this next hour, I do want this to be an interactive discussion. So we have the chat feature here. Please feel free to speak up. Shoot me a chat message. I would love to answer questions intermittently throughout this hour. Talk to you, get to know. Get to know you a little bit, answer questions that maybe if something I'm explaining doesn't seem, really clear. Also in this chat feature, you will also see a link to schedule a visit with me. And so this link, I want to clarify, is a link with my office manager. Her name is Cyrus. So it is not a direct visit with me. So when you click this link, it is a meeting with Cyrus, then ultimately to get on my books. I do save a limited number of spots for my webinar patients that reach out to us. And so when you click this link, it'll be a time slot to meet with Cyrus to talk about scheduling a visit. She'll get your insurance information and talk to you about when she can get you booked to talk with me directly. But I look forward to meeting with you guys individually. But today we're going to talk about this dismissal loop and why your pain keeps getting dismissed. And so I think this is very, very important to advocate for yourself, to learn more about endometriosis. Unfortunately, a lot of my patients have been dismissed. The average patient with endometriosis has seen 7 doctors, and it usually takes about 7 years to get a diagnosis. And this is really infuriating. I hope that in my lifetime and my my career that I can decrease this time frame for women to get a true diagnosis and ultimately get help sooner. Because the earlier we are able to treat endometriosis and start to reverse some of the sequela that endometriosis causes, the better our outcomes are. The better our outcomes are for pain, for fertility, for decreasing that central sensitization of pain. And so it's imperative to make sure that we're trying to advocate for ourselves or our family members and try to get treatment and a diagnosis as early as we can. So the first thing I want to talk about is dismissed symptoms do not equal normal. So there's a belief that's if I'm being told it's normal, it must be. I'm talking to a physician or I'm talking to somebody that has education and I'm told that it's normal. But this is absolutely not true. Dismissed does not mean normal. Just because something is common doesn't mean that it's healthy. So let's get specific. Pain that disrupts your day, not normal. Bloating that lingers, not normal. Fatigue that affects how you function, also not normal. And many of these symptoms are often associated with endometriosis, but they're minimalized early. So instead of being investigated, they're kind of explained away. And this is very common. This is something that I see frequently. A recent study I read showed that the most common symptom of endometriosis was fatigue. And I was making a PowerPoint lecture and I wanted to make sure I was up to date on the most recent studies. And as I was looking through this, I was kind of annoyed at first. I was like, fatigue, that does not help me. That does not help me diagnose this endometriosis. But it makes so much sense once I started thinking about it. Women with endometriosis have so much chronic inflammation. Their body is putting all of its energy and resources to managing that inflammation, and there's very little left in the tank. So fatigue, of course, is going to be a common symptom with endometriosis, and really it is with most chronic diseases. But it makes sense because your body has nothing left at the end of the day. It's fighting this inflammation, it's fighting these pain receptors and your cortisol responses. And the only thing you have left at the end of the day is just barely getting by. There's not anything left, not anything left to bring you joy, to exercise, to do things that may give you an endorphin surge, or just even just to relax. Sometimes even just relaxing is fatiguing because it's hard to downregulate all of these sensations that you're getting because of the endometriosis. And so, the first thing I want to kind of hit home is that dismiss does not mean normal. Endometriosis affects us in many different ways. It affects our mood. It affects it can affect our intimacy and cause pain with intercourse or our desire to have intercourse. It can affect our fertility and the ability to have children. It can affect our bowels and cause painful bowel movements. It can affect our bladder. It can affect our pelvic floor. It is really a debilitating disease, but it very much should be evaluated as a whole body disease. And I think that that's where some of the links are missing when you talk to other doctors that are just focused in, or you just complain of maybe one symptom, but not all of the symptoms together, frequently it's missed. And so it's really important to hear me that just because your symptoms aren't taken seriously or they're not investigated does not mean that they're not valid and that they should not be explained away. So the next thing I want to talk about, kind of the secret number 2, it's not just the symptoms you're experiencing, but it's also the pattern. So the pattern of symptoms also makes a difference. So here's where things start to kind of click for most women. So it's not about one symptom, it's about the pattern of symptoms. So ask yourself, is this getting worse over time? Is it getting worse over the last few years? Does this happen outside of your period? So classically, endometriosis starts with painful cycles. And then as endometriosis progresses, it starts to have pain outside of your cycle, rather pain with ovulation, the pain the week before your cycle. And then at some point you can have pain all the time, associated with endometriosis. Does it affect multiple areas? Does it cause pain with digestion or painful bowel movements? Does it affect your energy and your fatigue? Is there pain localized? Is it in a specific area? Does it radiate? Does it radiate to your back? Does it go down your legs? All of these patterns of symptoms are really important to think about when you're trying to put it all together. So you're nodding your head right now, and that matters because you're starting to see some of these symptoms and the patterns that are associated with them. These patterns are often where endometriosis shows up first. It's just not in a way that's immediately obvious. I had a patient that had been told for years that everything was, quote, fine. But when we mapped out her symptoms, starting from even a young girl, it wasn't random. There was a clear pattern. And the issue wasn't that nothing was there, it's that no one had put the whole picture together. And this is very, very common with my patients. So classically, endometriosis starts at a young age. We don't know everything about endometriosis, but we think these cells don't migrate where they're supposed to, even when you're in your mother's womb. So these cells implant elsewhere in the body, usually in the pelvis, because they're getting close to the uterus where they're supposed to be. But they can be, anywhere in your abdomen or thoracic cavity, but that's more less common. But as your body starts to make estrogen and starts to have cycles, the estrogen feeds the endometriosis. And that's typically when people start having symptoms, is relatively early. Not some people have had it from the very first period, from the very time they can remember their symptoms were just debilitating. Other people started to have symptoms at a younger age and saw it progress over time. But that's what's so tricky about endometriosis is it never regresses on its own. If it is true endometriosis, it will stay the same or worsen with time. And as it continues to worsen, you start to have pain outside of your cycle. So not just painful cycles, or it starts to affect your other organ systems like your bowels, your bladder, painful intercourse. You start to have, pain with ovulation, or down the road, some of these women start trying for pregnancy and they realize they're having trouble getting pregnant. They've been having, regular intercourse for these first year and they're not conceiving. So what is missing? What's also tricky about endometriosis, so that's sort of the classic progression of endometriosis once you start putting all the patterns together, is not everyone fits these patterns. Some people don't have symptoms until later in life. Some people start to have symptoms in their 20s, or some people even start to have symptoms in their late 30s, whereas they really didn't have issues before. But those patients, I find that that's where it's really important to really dig down into their history, because sometimes what they feel is normal, it's normal for them because that's the only thing that they've experienced. But once you really start talking to them about it, about what their cycles are like, what their bowel movements are like, or their constipation, painful intercourse, once you really start asking them very specific questions, you realize that maybe they had symptoms much earlier. They just weren't picked up because that's all the patient knew. That's all she knew. This was normal for her. And so she didn't think that it was outside of, the norm. Or my mom had this. This is how her symptoms always were. So I just assume this is normal for my family. And so it's really important to get a clear picture and really dive into the history when it comes to endometriosis. And I know you guys are exhausted from explaining yourself over and over and over and maybe getting dismissed. Hopefully not. Hopefully at some point somebody has listened to you along the way and really done a deep dive into some of the symptoms you're having and tried to connect the dots. But just know you're not alone. The average endometriosis patient, like I mentioned, is 7 years and 7 doctors before they start getting answers and a true diagnosis. But it is imperative to advocate for yourself and remember that being dismissed does not mean normal. And then also it's not just the symptoms you're experiencing, it's also the pattern of symptoms that you're having and kind of trying to connect the dots together. So the third thing I want to talk about is how dismissal turns into self-doubt. So this is the part that quietly affects women the most. When you're told repeatedly, you're fine. We don't see anything wrong with your imaging. This is normal, but your body feels anything but normal. You start to question yourself. You downplay your symptoms. You stop asking questions. And that delay is one of the biggest reasons conditions like endometriosis become harder to address later. Not because you ignored it, because you're kind of taught to ignore it. You've been told that it's normal. You have a normal ultrasound. We don't see anything that's wrong. Your lab work is all normal. Your physical exam, we don't see anything wrong. Or even MRIs. I've even had patients that have had, laparoscopy by someone that maybe didn't feel comfortable identifying atypical endometriosis or early endometriosis, and it was missed. So never stop advocating for yourself. Women frequently, turn into this self-doubt, and remember to listen to your body. If your body is telling you something's wrong, you are absolutely correct, and you should continue to advocate for that. And I am not perfect. I don't always know if endometriosis is causing your symptoms, but I will absolutely help you find the right answers. And if I can't find the answer, I'll reach out to colleagues that do. But most of my patients, once you connect the dot, you realize that there's a a bigger a bigger underlying issue, causing the symptoms. It's not just a pelvic disease. This is a whole body disease that is affecting all these different organ systems, the fatigue, your energy, your mood, because you're always in pain, or you're always chronically inflamed. And so it's imperative to listen to that. And if you start questioning yourself, just know you're not alone. Do not downplay your symptoms. Your symptoms are very real. They are not in your head. They are in your pelvis. I actually have a shirt that says this. I sometimes wear it to endometriosis conferences. Your symptoms are not in your head. They are very real. And never stop advocating for yourself and trying to connect the dots, to find answers and treatment. So dismissal that turns into self-doubt, trying to avoid that the best you can, and it's not your fault. You're kind of taught to start to listen to this, but it's really important to continue to advocate for yourself, because the longer endometriosis symptoms are present, the harder it is to reverse, the harder it is to address later. And I think that's something else that's really important. The earlier you treat the endometriosis, the better your outcomes. So if we can catch all endometriosis at stage 1 or stage 2 and treat them with good excision surgery and lifestyle management to decrease the inflammation, our long-term sequela would be significantly lower. And yes, there's still a risk of recurrence, but it is much lower. Less risk that it causes nerve damage, less risk that it affects your fertility, less risk that it's going to grow into the colon and require a bowel resection. And so the earlier we can attack and treat endometriosis, the better our long-term outcomes are, because we can start to reverse the sequela of the nerve damage, the inflammation, that central sensitization of pain that endometriosis is causing. Even the fatigue can be reversed. But the earlier we catch it, the better our outcomes. And it is imperative to keep that in the back of your mind. The hard part about this is women in general are less likely to be listened to, especially young women or women of color. And it is even more important to advocate for them, to listen to their symptoms, because what they're experiencing is not normal and it's not in their head. And so my patients, it's important to have kind of a team around you, whether it's your family, whether it's your friends, whether it's people on social media that are experiencing similar symptoms, trying to, not get discouraged. Remember, dismissal does not equal normal. Not letting that self-doubt kind of creep in, and really working on advocating for yourself and trying to explain your symptoms and that pattern, again, the pattern of symptoms that you're experiencing, so that we can connect the dots to try to figure out what's going on. And frequently endometriosis is associated with all of these different organ systems. Okay, so I'm going to take a little break from the discussion today and go over to the chat. Again, please feel free to shoot a message over on the chat. I would love to get to know you individually or ask them some individual questions. You can also send me personal messages, just one-on-one, and I'll try to get to a few of these today. Again, I'm Dr. Rachel Haverland. I'm with Endometriosis Center of Excellence here in Dallas, Texas. Also in the chat, you will see a calendar to where you can schedule a visit with me. Now, remember, this calendar link is actually going to give you a visit with Cyrus. Cyrus is my office manager. She will be able to go over your insurance and then at that point get you scheduled for a visit with me. So remember, this link, this calendar that you're using right now is not a direct visit with me, rather a specific time to meet with Cyrus, my office manager, to get you on the books. Let's see. This is a good question. How can you tell if your pain is endometriosis versus fibromyalgia, or it's both? That's a good question. So endometriosis is a chronic inflammatory disease, very similar to fibromyalgia. Recently, less of my patients have been getting a diagnosis of fibromyalgia, and rather more with like EDS or Ehlers-Danlos syndrome, because again, it's this chronic inflammatory disease. And sometimes it is difficult to differentiate. And that's why you really have to listen to some of the symptoms. When did your symptoms start? Are they progressively getting worse? Are they exacerbated by your period? Are they affecting your bowels? Are they affecting your bladder? An exam or imaging, how is this helping? Endometriosis certainly can cause joint pain because of this chronic inflammation. Now, it's not endometriosis usually, specifically in your joints, but it can contribute to some of the joint pain that patients feel. So some of my patients feel like I literally have knee pain during my cycle, or shoulder pain. Shoulder pain can be related to, endometriosis affecting the diaphragm or pain that's radiating to your shoulder. And so it's really important to listen to the symptoms and try to connect the dots. And it's not always black and white. And so we can treat the inflammation as a whole by treating you in a multidisciplinary way to decrease that inflammation. But sometimes we do have to move towards surgery to get a definitive answer and hopefully a treatment of endometriosis. So that's a very good question. Okay, so this patient said she had excision surgery and was able to get pregnant. Yay, congratulations. But she did have trouble during her pregnancy with pain. And now that her periods are recurring, her symptoms are worsening. And unfortunately, we do see this sometimes with endometriosis. During pregnancy, your progesterone is really high. And so it can help kind of subdue some of that inflammatory response from the endometriosis. Another thing to really consider is adenomyosis, which is uterine inflammation. So if you had a true excision surgery, depending on what your stage was, this may be adenomyosis kind of creeping back into the picture more so than endometriosis, but it's adenomyosis tends to worsen with pregnancies and subsequent pregnancies, worse after C-sections, but certainly can happen after vaginal deliveries. But also something to sort of keep in the back of your mind that this may be an adenomyosis type picture also causing this inflammation, especially if the pain is specific during your cycle. Sometimes that may be an adenomyosis related symptom, but important to talk about. Let's see. Okay, this is a good question. Let's see. So how do you tell the difference between endometriosis recurrence, adhesion, scar tissue, pelvic floor dysfunction, and the nervous system? When do you know it's time for an additional excision surgery? This is a very difficult question. If I knew this answer, I would be a millionaire because it is very difficult to identify, to be honest. And it depends on kind of your first surgery, how advanced the endometriosis was, if you have deep infiltrating endometriosis, and what you've been doing afterwards. I always try to implement a multidisciplinary team. So diet, exercise, physical therapy. Some people I recommend doing acupuncture or dry needling. They also sometimes my patients see a physiatrist, patients that work with pain management or inflammation management, giving medications to help with nerve pain, gabapentin, Lyrica, nerve injections, medications to help the pelvic floor like vaginal suppositories. And so if you're doing all of these things and you have been since surgery to really minimize the inflammation, I think it is reasonable, to talk about an additional excision surgery, but you have to make sure that your surgery is truly an excision, like an aggressive peritonectomy, wide margins, that your surgeon feels very comfortable getting all of this disease out. And then we also have to have the discussion is repeat excision surgeries. If your first surgery was a true excision, does tend to give less and less benefit. And so it's really important to have that in the back of your mind. We don't want to keep doing surgery over and over. Surgery every year is not good medicine. It leaves behind scar tissue. It causes damage. No matter how good you are, you're going to leave behind some scar tissue, during the operation. And it's important to keep that in the back of your mind. So if I start to see a patient where I've done an excision surgery, relatively recently, and they start to have symptoms, I make sure that we are, incorporating these other modalities to decrease the inflammation. Some of my patients have seen improvement with like low dosing GLP-1s, just because of the way that it decreases the glucose responses that can contribute to inflammation. So some of my patients have tried that to see if they can see an improvement. Sometimes we try medications. If patients aren't on medications like progesterones, for example, especially for adenomyosis, even with endometriosis, there has been some people do get a benefit with birth control pills or progesterone. So talking through all of your options, and making sure you're really being thorough for longevity before just jumping back into a surgery. Again, because each additional excision surgery does tend to give less and less benefit. And it's not impossible that endometriosis comes back. That is certainly possible. Endometriosis is a very difficult disease. It doesn't follow the rules. It can be very aggressive. It can make its own estrogen from other hormones. And so sometimes it's hard to anticipate, but really listening to your patients, studying their initial op report and their path report, looking at pictures, seeing what was done, but also making sure that we're implementing all these other modalities before jumping right back into surgery. Because again, repeat surgery statistically gives less and less benefit. And I'm not saying I won't do it, but you also have to understand the risks that are associated with it and understand that there's a chance that you're not going to see the benefit that you were hoping for. Um, all right. So, okay, what do I do with postmenopausal endometriosis? And I see this a lot. So there is a falsehood out there that once you reach menopause, endometriosis resolves on its own. And that unfortunately is not true. Women that have had their ovaries removed, not placed on HRT, can still have active endometriosis. Women that naturally go through menopause, average age of 52, you can still have active endometriosis. I see this about once every 6 months. Once every 6 months, I go in and for surgery on a woman that's postmenopausal, and we see active endometriosis under the microscope. Now, postmenopausal women and prepubescent women, their endometriosis can look a little bit more atypical. Sometimes it's a little bit more difficult to identify. The endometriosis can be more subtle. It looks like scar. It looks like a little red staining or hemosiderin staining. There can be little clear blisters. Sometimes you go in and it's a very classic endometriosis with big black lesions, kind of the classic powder burn lesion. But one, it's important to make sure you identify the endometriosis. And then two, feel comfortable removing it from wherever it is, whether it's from the bowels or near her nerves or the ligaments or the ureters, but making sure that we're very thorough in evaluating these areas. But postmenopausal endometriosis is very real. And at that point, hormonal management is really not a great option because they're already postmenopausal. They already don't have their estrogen. Their endometriosis is getting fed estrogen from the other hormones. It's using that aromatase property to transition to other hormones. And so at this point, we talk about excision surgery and also making sure that we're treating the inflammation from all angles, all areas that we can, whether it's physical therapy, acupuncture, nerve injections, medications to help with the inflammation overall. Diet is a big one for women with endometriosis because your bodies just don't respond to they don't respond to foods the same way that somebody else without a chronic inflammatory condition has. And so they're more sensitive to foods. Gluten is a common one. A recent study showed at least 70% of women with endometriosis had some sort of gluten sensitivity. Now, this does not mean you have a celiac disease, but gluten can just be so common in how it affects the body and how it tends to be more inflammatory. The next most common food group is dairy when it comes to chronic inflammation. But this is not a one size fits all. And I always talk to patients about this. I wish that I had a perfect endometriosis diet, an anti-inflammatory diet, but really working on individualized treatment. So cutting out a food group for a few months and seeing if it improves your symptoms, adding or subtracting foods. I like whole foods diet, which is fruits, veggies, lean meats, and then adding or subtracting foods as you feel like you can tolerate. Diet is hard because you don't get that immediate positive feedback. So you don't eat well one day and feel good the next day. That's a little bit frustrating. You have to do this for like a month or two at a time before you start to see the benefit. I do have nutritionists that you can work with to help kind of guide you in that way to help with diet and trying to find foods that are more inflammatory for you, but really working towards that, I think it can be beneficial long term. One more question, and then I will jump back to the discussion today of the webinar. Question: have you had a lot of experience with incisional endometriosis and a C-section scar? Unfortunately, yes, I do. Now I'm kind of a zebra because everything I see is endometriosis. So I see a lot of these. I probably see 3 or 4 C-section scar endometriomas a year. Sometimes we're able to remove it without placing mesh. Sometimes you do have to place mesh because it is so large. I will say most of the time, the endometriosis is not just on the C-section scar. That's where we identify it. That's where it's growing. That's what you can palpate when you push on the tummy or on the abdomen. But frequently, endometriosis is also elsewhere in the pelvis. It's kind of like an endometrioma or a chocolate cyst on the ovary. When we see this on imaging, it is never just on the ovary. If you have endometriosis on the ovary, you're already automatically stage 3 disease. When you have an endometrioma or an implant on your C-section scar, it is very rarely only on that fascia and the C-section scar. Sometimes you can see it from laparoscopically from down below. Many times we have to make an excision near where your C-section scar is to make sure that we get it out, fully and with really wide margins to try to help prevent it from recurring. Frequently, I work with general surgeons or even a plastic surgeon to make sure that these are excised completely and then help identify if mesh is needed or not. But unfortunately, these endometriosis implants are relatively common. Sometimes you can see it in laparoscopic ports too, like even from laparoscopic surgery, you can have endometriosis spread to where the port sites were because any like microscopic cells can implant on those areas and ultimately form an implant that grows, can be filled with chocolate fluid. Usually when we remove these areas at time of surgery, they're actually just very hard. They're very fibrotic, almost like a rock. Usually you don't see like big pockets of fluid. You see like tiny pockets of fluid and change in the color, but most of it is just very hard and fibrotic because endometriosis ultimately just causes a lot of inflammation, which is causing a lot of scarring. And so you can feel that underneath the skin when you do a palpation. Those are great questions. So thank you guys for entertaining me a little bit and letting me pick some discussions up from the chat. We certainly will go back through that again at the end of this webinar to touch base again to answer some of the chat questions. Again, I'm Dr. Rachel Haverland with Endometriosis Center of Excellence in Dallas, Texas. On the chat, you will see a link to schedule a visit with me. This is when you click on this link, this time it is not a direct visit with me. This is a visit with my office manager. Her name is Cyrus. At this time, she will get your insurance information. She will look at the schedule and give you our earliest available appointment. I do hold a very few patient visits for my webinar patients so that hopefully you can get in a little bit earlier. But ultimately, I would love to meet with you and talk with you one-on-one about your individual story and what endometriosis looks like for you and kind of try to help put some of these pieces together. And so as we go through the webinar today, like I mentioned, we were talking about why does your pain keep getting dismissed? And, very familiar to most of you. You explain what you're feeling very clearly, very calmly, and you leave your visit with your provider feeling unheard. You talk about all of the symptoms that you're having, the bloating, the exhaustion, the fatigue, and it's just not being put together and it's not really being explored. And so your body keeps trying to tell you that something is wrong. And it's really important to listen to that, to listen to your intuition, advocate for yourself, advocate for your family, advocate for your friends, your sister, your wife. Women with endometriosis frequently are dismissed. The average patient, like I mentioned, takes 7 years and 7 doctors before they start getting answers. And a lot of this has to do with not putting the patterns of the symptoms together, not listening to the patients, also not really knowing what to look for because endometriosis is not just a pelvic disease. It is very much a whole body inflammatory disease. And so it's important to make sure that we're treating it as such, not just treating it with hormones alone, but really managing the multidisciplinary treatment plan that also includes surgery with excision because symptoms are often linked to chronic conditions like endometriosis, but again, instead of being explained, they're dismissed. And so I think that it's really important to try to avoid this dismissal loop the patterns of what happened to you after you speak up. You kind of get tired, you bring it up, you're told it's normal. It happens again, you bring it up again. And ultimately, you stop pushing, you start thinking, you start having some self-doubt that maybe you're overreacting. But this dismissal loop is um, really debilitating. Not just individually, emotionally, physically, but also to the diagnosis of endometriosis. Because once you start to let that self-doubt kind of creep in, you stop advocating for yourself. You stop talking about it. And again, I don't know everything. And sometimes we don't have endometriosis, and that's okay. We start looking towards the next steps or what we need to work towards, but never stop um, discussing your symptoms, because your symptoms are very real. They are not in your head, they are in your pelvis, and they are causing inflammation, and it's affecting your body as a whole. And so I want to make sure that we talk about this. All I do is endometriosis. So I'm a little bit biased. I only see endometriosis patients or patients that have a high suspicion for endometriosis, or find me, on the webinar, or find me online, or call. Um, However, almost everybody is right. Less than 1 or 2% of my patients, we go to surgery and they don't have active endometriosis. It's really infuriating how many patients have had to go through different treatment plans and different options before they get the gold standard of care for endometriosis, which is excision surgery, to identify the endometriosis and to excise the disease. And so it's really important to understand the patterns that are consistent with endometriosis, and really listen to what your body has been trying to say. So dismiss does not equal normal. So just because something is common does not make it healthy. Kind of endometriosis frequently is dismissed because women tend to have cramping with their period. But women that have a normal period, start their period, they take some ibuprofen, they go for a run, they go to work, they call you like, hey, do you want to go have dinner later? That's normal. That's expected. Some mild cramping, but it's not negatively affecting your day. It's not negatively affecting the way that you function. It's not affecting your work. You're even able to exercise. That is how a cycle should be. When your pain is debilitating, when you're on the floor, when you're vomiting related to your pain so severe, when you can't go into work, when you really can't think straight, having to go to the ER multiple times for severe pain, that's not normal. Bloating that doesn't go away, where patients are asked if they're pregnant, is also really debilitating. The bloating can be uncomfortable. You see the abnormality, you see the inflammation in your body, and you're trying to do something about it, but you can't figure out what. You can't figure out how to decrease that inflammation or to improve the bloating and the distension that you have. Bowel symptoms. So sharp stabbing rectal pain when you have a bowel movement, that is not normal. Chronic constipation when you're only having a bowel movement every few days, when you're passing pebbles, when you have painful bowel movements, that is not normal. Very common. That is related to endometriosis. Many of my patients have been diagnosed with, quote, IBS, like alternating diarrhea and constipation. And yes, you can have more than one diagnosis. You can have endometriosis and IBS. But frequently the bowel symptoms are related to the endometriosis, especially when you see this fluctuation around your cycle, sharp stabby pains that are radiating. Another thing that's really important is the bladder. So women with endometriosis frequently have bladder symptoms. When their bladder is full, it is uncomfortable, or they feel like they have a UTI, but they keep going to the doctor and checking your urine cultures, and the cultures are negative, or it's not showing active bacteria, but they still feel like they have a UTI. It kind of comes and goes. The bladder is always irritated, frequently associated with endometriosis. Painful intercourse is also very common. So sometimes it's like at the opening, sometimes it's deeper penetration, but the pelvic floor dysfunction, these muscles on the pelvic floor, don't work very well when you're in pain. They tense up for your body to try to protect you. The nerves run in your muscles. So when the muscles are affected, it also affects your nerves. But there's a lot of subsequent sequela that endometriosis causes, downstream effects. There's also something called silent endometriosis where you're having trouble getting pregnant. If you're trying for pregnancy for, over a year and you've done a workup, they can't find anything wrong. The semen analysis is normal. Your tubes are open. You have normal ovulation and you're not getting pregnant. It's reasonable to look for something else. Silent endometriosis or endometriosis is the most common cause of unexplained infertility. So frequently associated with endometriosis and the inflammation that this is causing. This inflammation affects the egg quality. It can make it harder for the egg and the sperm to fertilize in the tube, and then it can affect implantation and early first trimester miscarriage. So endometriosis is really it really affects us in many different ways. And I feel like frequently it's brushed off because if it's not like specifically a pelvic disease or associated with your period, sometimes it's not taken seriously. And so it's important to explain all of your symptoms and really understand this pattern of endometriosis. So again, is it getting worse over time? Is it starting to happen outside of your period? Does it affect multiple organ systems? Are you starting to have pain, during ovulation or the week before your cycle? So this matters. If you're starting to see these symptoms and you're realizing this pattern, endometriosis shows up first, just not in a way that's immediately obvious. And it's important to kind of try to put all these pieces together to understand. And that's what I try to do in my office visits. Really just listening to your history, letting you talking about your symptoms, how they progressed, how they've changed, how your symptoms were when you were young, maybe how your symptoms are changing throughout time. And it's not a one size fits all. Again, endometriosis does not follow the rules. Some women have all the symptoms of endometriosis and other people have a very, kind of focused symptom. And that's where you really have to be open-minded about endometriosis and understanding how the process works, how it affects your nerves, but how it's affecting your body as a whole. So, when we mapped my patient's symptoms, it wasn't random. There is a pattern, and it's not that there was nothing there. It's that no one had really put the picture together. And so it's really important to try to connect those dots. Next we talked about, self-doubt, not trying to let that creep in. Your body does not feel normal. Listen to your instincts. When you start to question yourself, you downplay your symptoms, you stop asking questions. It makes it harder to address endometriosis when it's later. When the endometriosis has continued to progress, the more advanced it is, the longer it's caused nerve damage, the longer it's caused pain when your pelvic floor, the harder it is to reverse some of those sequelae. So here's what I want you to take with you. If something feels off, even if you've been told it's normal, that matters. If your symptoms don't match what you've been told, that matters. And if you've ever left an appointment feeling unheard, that's not the end of the conversation. That's the beginning of a better one. So that's exactly why my team and I offer private clarity consultations, because most women don't need more options. They need a clear understanding of their own pattern. On this visit with me, we walk through your symptoms in detail, identify what may have been dismissed or overlooked, help you understand if your patterns align with conditions like endometriosis, and then we map out your next best steps. So this isn't about rushing into treatment. It's about finally making sense of what's been happening, giving you all of the information and all of the knowledge about your treatment options so that you can make the best decision for you. And again, this is not a one size fits all. This is not an algorithm. Endometriosis treatment should be very individualized. Not everybody needs to jump into surgery right away. Many of my patients already tried, some of the less invasive treatments already. So maybe surgery is the next step for them. Some people feel comfortable trying medical options like hormones. Other people really don't. They've had side effects, or they have a family history, or they just don't want to take any type of synthetic medications. And so it's important to individualize treatment and help you make sense of what's happening by giving you more information to allow you to make the best decision for yourself. So, like I mentioned, we only open a limited number of consultations each month. This is individualized, personalized sessions. Once the spots are filled, we close the calendar. Right now, in general, we're booking in September, but we do have some openings, before then. So if you're tired of being told that everything is normal, wondering if something has been missed, or really ready to understand your body more clearly, now is the time to take the next step. So imagine this. Imagine finally understanding why your symptoms never added up, what your body has been trying to tell you, and what to do next. No more second guessing, no more dismissal, and no more confusion. Just clarity. And clarity, that's what changes everything. And when you start to understand your body and what is going on inside, it helps with making next steps and decisions a little bit easier because the clarity is there. Um, so thank you guys for meeting with me for the last hour. I'm going to go back into the chat and answer a few more questions before we're done today. But again, I'm Dr. Rachel Haverland with Endometriosis Center of Excellence. I specialize in endometriosis and endometriosis excision. In the chat, you see a calendar where you can schedule to meet with me. So this calendar invite, this is a specific time to meet with my office manager. Her name is Cyrus. At this time, she'll go over your insurance and get you put on my schedule. So this patient said, I suspect that I may have sciatic endometriosis, and I didn't even know that was a thing. Unfortunately, yes. So endometriosis can affect the nerves in the sacral promontory, which can radiate similar to sciatic pain. Also, there are some patients that do have true endometriosis on the sciatic nerve. So the endometriosis grows down near that sacral plexus, which can cause sciatic pain. Another thing that's interesting is sometimes adenomyosis or uterine inflammation can mirror or mimic sciatic nerve pain because the uterus is very heavy, causing inflammation. It sits there on the sacral promontory, and this pain radiates to your back. So pain radiating to your back or down your legs is frequently associated with sciatic pain, adenomyosis, or endometriosis affecting like the sciatic nerve plexus, which can sometimes be difficult to differentiate, but it's unfortunately very, very common. Okay. Do you collaborate on known diaphragmatic endometriosis? So yes, I do have a cardiothoracic surgeon that helps me with diaphragmatic endometriosis. I do most of my own diaphragm endometriosis. I feel comfortable with these dissections. However, if the endometriosis is growing into the thoracic cavity, so sometimes we get in and there's fenestrations on the diaphragm, like you can literally see the lung pleura between it. People that have pneumothorax or catamenial pneumothorax, which means their lung collapses during their cycle, or any type of similar symptoms. I have a cardiothoracic surgeon that will come in and help dissect out that area and make sure that the diaphragm is restructured appropriately. So I do most of my own diaphragm endometriosis. I do feel comfortable doing that. But if we get into the lung pleura into the thoracic cavity, in which rather a patch may need to be placed on the diaphragm, depending on how big the endometriosis area is, or if we're going into the pleural workspace, then I would have my vascular surgeon come in and help. Typically, if you're having to go into the lung cavity, they request to have two separate surgeries, one surgery for the pelvis endometriosis and a separate surgery for the lung endometriosis, because after you have a thoracic disease, you have to have a chest tube. This can also be very uncomfortable. It's a lot for your body to do at one time, both the pelvis and the chest. And I realize different endometriosis centers across the country do this a little bit differently, but I've done one or two in which the pelvis was done simultaneously with the lung, and I will say it's a really difficult recovery and very uncomfortable. It's also hard to really focus on healing when your body's in such an inflammatory state. So I usually recommend at this point, if we have to do a through and through diaphragmatic dissection, that we do that separately if we're having to go into the thoracic cavity. Now, if it's superficial on the diaphragm, I can clean it off. That's not a problem. But if we're having to go all the way into the thoracic cavity, then I would have my thoracic surgeon do that at a separate time, because you'll need a chest tube, stay in the hospital for a few days, make sure that all that is healing the way that it should be without having to also heal from the pelvis. But I think that is really important, because there frequently is endometriosis on the diaphragm. So it's important to be able to feel comfortable excising endometriosis from the diaphragm. And then also, if it is through and through lesions, that's a larger area, having a specialist that can help with management of that and making sure that you feel comfortable with excisions. because excision surgery again is the gold standard. Um, if we leave the endometriosis on the diaphragm, it just continues to grow, and that fenestrations or that areas on the diaphragm continue to worsen with time. And so it's kind of an uphill battle. But unfortunately, endometriosis is something that can't just you can't just put a Band-Aid on it. It's something that needs to be excised, or you're not going to be able to see the benefit. Um, let's see. Um, What's the first steps after endometriosis, hysterectomy, and excision? So, I recommend making sure you're really focusing on your diet, decreasing inflammatory foods, working with the nutrition, starting to get back into exercise, physical therapy. And I know this is a lot on your plate, but really decreasing the inflammation the best you can. If we get out and you're doing all of these steps, diet, exercise, physical therapy, acupuncture, I do think it's reasonable to see if a progesterone could help some of your symptoms. Even after a hysterectomy, sometimes progesterone can help some of the inflammation. If there's like microscopic endometriosis, or even some of the damage that endometriosis is done with time. And then next steps, I would have you meet with a physiatrist, which can do nerve injections or other management of nerve pain, like medications to help with nerve pain, injections, making sure we're really covering our bases for different modalities. Imaging is not perfect. That's one of the difficult parts about endometriosis. So an MRI is usually the best way to evaluate for endometriosis or deep infiltrating endometriosis recurrence. But again, it's not perfect. So a lot of it is based on your symptoms and how you're feeling, but making sure you're treating the inflammation as best you can from all the different angles. Sometimes endometriosis has been there for so long, it causes a lot of nerve damage. And so letting the nerves heal and reset sometimes can take a really long time. But important to listen to your body and consider, progesterones, or consider nerve injections or medications if you did have a true excision and still having symptoms, afterwards. So, anyways, it was lovely to meet with you guys for the last hour. I think that it's really important to advocate for yourself and remember, clarity is what changes everything. Really understanding what's going on in your body and giving you that information so you can decide what is best for you. Knowledge is power. So once we really start to understand what's going on, you're able to make better decisions for you and your body as to what are best next steps. Rather it's less invasive treatment, rather it's hormones, rather it's surgery, but just really advocating for yourself. But once you get that clarity, hopefully you'll better understand what's best for you as far as next steps go. So thank you for meeting with me for the last hour. Again, I'm Dr. Rachel Haverland. In the link in the chat, there's a link to meet with my office manager to schedule a visit with me. Like I said, I would be honored to see you and have a one-on-one visit with you and really talk through some of your symptoms. I think that you deserve answers and not to be dismissed. So I'm looking forward to talking with you at your visit. I hope you guys have a good rest of your Wednesday, and I look forward to seeing some of you in the office. Otherwise, maybe at my webinar next month. Y'all have a good rest of your day. Bye-bye.